All right, let's dive right into a topic that is absolutely critical if you're in healthcare. Neural tube defects. This is one of those core concepts you're going to see everywhere, from your exams right into your clinical practice. So let's get into it.
So here's how we're going to break it all down. We're going to start with the very basics, what I call the flaw in the blueprint. Then we'll get into the different types you'll see, figure out the causes and risks, and then walk through diagnosis, treatment, and of course the hands-on nursing care that really makes all the difference.
Okay, first up, that flaw in the blueprint. To really get a handle on neural tube defects, we have to rewind all the way back to the very first weeks of development, where one tiny mistake can change absolutely everything. So what exactly is going wrong here?
So a neurotube defect, or NTD, is a birth defect that affects the brain and the spinal cord. Now, the most crucial thing to get from this slide is the timing. This isn't some problem that pops up late in pregnancy. It happens incredibly early on, between the 3rd and 4th week, often before a person even realizes they're pregnant. This little structure, the neural tube, is supposed to do this simple fold and close maneuver to become the entire central nervous system. When that one little step fails, well, the consequences are just massive.
This right here. This is the devastating chain of events. It's like a domino effect. First, the tube doesn't close. That leaves an open spot, a defect. This then exposes those super delicate nerves to the amniotic fluid, which can cause infection and ultimately leads to permanent neurological damage. It's a cascade, you see. One initial failure results in a lifetime of impact.
Okay, so that's the how, that's the mechanism. Now let's look at the actual conditions this can lead to. And it's so important to understand that NTDs are not just one single thing, they exist on a whole spectrum, from something that might be totally hidden to something tragically severe.
This table is your absolute key to understanding Spina Bifida, which is the most common NTD. So look, on the left, we've got Occulta, that's Latin for hidden. The vertebra isn't totally closed, but nothing is sticking out. Easy enough. In the middle, Meningocele. Now, the meninges, that's the protective blanket around the spinal cord, and some spinal fluid, or CSF, push out into a little sac. But the cord itself is still safe inside, so the prognosis after surgery is usually pretty good. But then, look to the right. Myelomeningocele. See that star? That's there for a reason. This is a huge exam topic. In this case, both the meninges and the spinal cord itself are bulging out in that sac. This means nerve damage is guaranteed, leading to things like paralysis and incontinence. So the big takeaway is this: what's inside the sac changes everything. Next, we have to talk about the most severe form of NTD, and that's anencephaly. In this really tragic condition, the top part of the neural tube fails to close, which means the brain and the skull just can't develop the way they're supposed to. There's no treatment for this, and unfortunately, the condition is incompatible with life.
And finally, just to round out the main types, there's encephalocele. This one's pretty rare. It's kind of like myelomeningocele, where a sac protrudes, but in this case, it's poking through an opening in the skull, and it actually contains brain tissue.
So we've covered the what. Now we've got to ask why. What causes this incredibly important developmental step to just fail? Let's put on our detective hats for a second and see if we can unpack the triggers that put a pregnancy at risk.
Let's just ask it straight up. What are the factors that can throw this whole process off track? What causes this blueprint to fail? Okay, here's a fantastic way to remember the key risk factors. The mnemonic, fat mom. Now, the F is the big one, the one you hear about all the time. Folic acid deficiency. This is exactly why prenatal vitamins are pushed so heavily. A is for certain anti-epileptic drugs, like valproate. T stands for toxins. And the last three, MOM, are for maternal diabetes, obesity, and malnutrition. These are all major, evidence-based risk factors you need to know.
Okay, so understanding the risks is half the battle, right? Especially when it comes to prevention. But what happens when an NTD is actually suspected? Let's switch gears to the clinical response. How do we find these defects and what can we actually do about them?
Diagnoses can happen either before or after birth. Antenatal, that's before birth screening, is super important and again, a high-yield topic for any exam. A simple blood test can check for maternal alpha-fetoprotein, or AFP. If those AFP levels are high, it can be a red flag for an NTD. From there, you'd move on to a detailed ultrasound or maybe an amniocentesis. Of course, after birth, a diagnosis can be made just with a physical exam and then confirmed with imaging like a CT scan or an MRI.
When you look at the treatment plans, the contrast is just stark.
For something like myelomeningocele, it is all hands on deck, immediately. The goal is urgent surgery to close the back, usually within the first 24 to 48 hours, to protect what's left of the spinal cord. A lot of these babies also get hydrocephalus, that's fluid on the brain, so they need a VP shunt to drain it. Now compare that to anencephaly, where there's no surgical fix and the entire focus shifts to supportive comfort care.
And that brings us to our last, and I think most practical, section, nursing care. For all you students out there watching, this is where the textbook hits the bedside. This is what you actually do on the front lines.
Okay, listen up. Before that newborn ever makes it to the operating room, you have one single overarching goal that guides every single thing you do. Your number one job above all else is to protect that sac. Everything else is secondary. Got it?
So how do you do it? 3 key things. First, positioning. The baby has to be placed prone. That's on their tummy or side lying. Never, ever, ever put them on their back. That puts direct pressure on the sac and you risk it rupturing. Second, sac care. You're going to cover that defect with sterile gauze soaked in saline. This keeps it moist and stops it from drying out. And finally, you're monitoring like crazy for complications, especially hydrocephalus, by measuring their head circumference every day and checking for bulging fontanelles, the soft spots on their head. All right, so the surgeon has closed the defect. The immediate crisis of protecting that sac is over, but our job, it's really just getting started. Our priorities now totally shift to managing a very complex post-op patient, preventing complications, and supporting the family for the long road ahead.
Post-op care is a whole new ballgame. Now you're watching the surgical site for any sign of spinal fluid leakage. You're managing pain, keeping the wound clean, and if they got a VP shunt, you're monitoring to make sure it's working right. But it's so much more than that. You're already starting long-term care, like bladder training and doing range of motion exercises to prevent their joints from getting stiff. And maybe the most important thing you do, you provide that education and emotional support for the family, helping them feel empowered to care for their child.
So we've seen just how devastating these defects can be, but we've also seen the incredible power of prevention. I mean, folic acid has been a public health miracle. It has slashed the number of these cases, but they still happen. And that leaves us with a really important question for the future. As our technology and genetic screening and even in utero surgery gets better and better, how are we going to manage the cases that still slip through? That's really the challenge for the next generation of clinicians.